Can I just explain? I'm sure everybody, I recognise most people and probably know how we're doing this, but just for the benefit of somebody who might not be, we're trying to run it like a select committee with witnesses. We'll give each witness a few minutes to say something or add something to what they've sent in if they want to, and then we'll proceed with some questions. I'm a very, very nice person, and therefore, when it comes to the end of that, well, that's what my mother says anyway. When it comes to the end of that, if there's some people in the audience who wish to add something, I'll bring some of you in then, because the purpose of this, as you know, is to try and produce by November some suggestions, some recommendations to the health service as to where we go, both with the diagnosis and obviously the treatment of this dreadful disease. And if you've got this, you'll see at the end of it, which we're quite pleased about, that we're hoping to have a report ready on the basis of this investigation for the 25th of November. I'm quite pleased it's in here. The Secretary of State himself has agreed to come and get the presentation. And we had a little meeting the other day, and we're hoping to pull off another bit of a surprise, but we'll see if we manage that for the 25th of November. So that's, if you like, the format. And can I also say, in terms of the witnesses, which I've said, if it occurs when you leave this august building that you should have said something or you forgot to do, then please feel free. It's been quite good, actually. The numbers of people we've had who've written in, just giving their own experiences. Sometimes you can imagine how difficult it is for somebody to go back through what has occurred to them, but people are doing that and are emailing it in, and we are looking at all that as evidence. And some of it, and I was going to just finish on this point because it just occurred to me, some of it, when we go through these, becomes very repetitive. Now, I'm a politician, Nick here is a politician. The great line in politics is, keep repeating the same line, because eventually somebody will get it. And that's all we're trying to do here. So don't worry about the repetition. It helps. Right, let's start off then. Which way around do we want to go? I've got Alex first. Yeah?
Okay. Just to say, I think people know, but Pancreatic Cancer UK is a national charity, and we are fighting pancreatic cancer on all fronts. So support and information, campaigning and research. So that's where we are. Having said that, today we wanted to focus on two areas, really. Early diagnosis and, in particular, emergency admissions to hospital, because we have some new evidence around that, some new data which we thought would be of interest to the gathering here. We also wanted, though, to highlight the pancreatic cancer patient experience. We feel we have a good insight into this because of our support line that we run and the information that we provide, which is nurse-led. So you will be aware of the challenges of early diagnosis for pancreatic cancer, so I won't go into the detail of that. And given the fact that there are those challenges, it's no surprise that 50% of all pancreatic cancer diagnoses are made as a result of emergency presentation to hospital, i.e. through A&E, a fact that you'll also probably know. You'll see from our written submission that we now have some additional evidence that reduced emergency admissions diagnosis would have a significant impact on one-year patient survival rates. We know from recent analysis that the National Cancer Intelligence Network did for us that if pancreatic cancer emergencies were halved and these patients were diagnosed via the 2-week cancer wait route, then as many as 150 more patients would survive a year or longer. So in terms of the one-year measure, the one-year survival measure that's become increasingly important over the last couple of years, that is significant data, that's important data. We also know from recent research which Imperial College did for us that the average length of stay in hospital for a patient with who is diagnosed with pancreatic cancer who has gone through the emergency process is 13.2 days, and that's almost double non-emergency cases. And we've talked to some of the clinical experts that are on our medical advisory board about this, and they tell us that that would undoubtedly lead to delays in access to diagnostic techniques and delays in treatment of symptom relief. So it has, again, an impact on patients. We're obviously very concerned with the human costs of this data, but Imperial College's research also showed that there's a financial cost as well. It demonstrated that pancreatic cancer emergency admissions cost about 3 times the combined average emergency admissions for all NHS patients. So this is costing us quite a bit of money. In fact, over £14.5 million annually, which is the cost of pancreatic cancer emergency admissions in the NHS. And that's a significant burden, particularly, as we know, given how much pressure there is on A&E at the moment.
Yeah.
So I think that's important information. So our submission outlines a number of recommendations, but I just really wanted to highlight a couple to you. Firstly, in light of our new evidence, what we would like to see is a firm government commitment made to reducing pancreatic cancer emergency admissions by at least 10% within 3 years, which would have an impact on 1 year survival rates, quite significant impact. And then with a long-term view to halving those, which would have the impact on the 150 people living longer. In addition, Pancreatic Cancer UK's Early Diagnosis Summit in 2012 highlighted the need to strengthen the cancer referral pathways for patients with non-specific and persistent symptoms where there's a suspicion of cancer. And this is something that was discussed quite a bit by the clinicians giving evidence at the last meeting that we had. So essentially, via their GP or indeed A&E, patients with non-specific symptoms, i.e. pancreatic cancer patients potentially, may well have several different and separate routes that they go into secondary care via. Different specialists who would investigate their problem further. And what happens is they'll be sent in by the GP, they'll need to return to the GP for their results, and if the problem hasn't been identified, they're then sent off to another different specialist who will start the whole process again. So these people become like a ping-pong ball, and it's therefore hardly surprising that people are going backwards and forwards to their GP over a period of time. This must be one of the reasons. There will be others. So apart from the distress that causes, obviously this also delays diagnosis, and those are delays that pancreatic cancer patients can't afford because it has an impact on survival rates. So we feel, drawing on the discussions at the last meeting, that there is an urgent need for local commissioners in the new structure to commission providers to offer a single point of referral for the coordination of cancer diagnosis for patients who have got unexplained or non-specific symptoms. So how that might work would be a suitably qualified, call them a diagnostic pathfinder, who's in secondary care, in discussion with the GP, could have quick access to specialists and tests, and would not let that patient go without coming to some kind of conclusion, either that the patient hasn't got anything seriously wrong with them or a diagnosis. And we think that could have a significant impact on the problem of early diagnosis. And we also believe that rapid access clinics for patients with sudden emergency onset symptoms, so jaundice, should also be a priority. So there's a case study for this in our submission in Southampton, where they've set up a clinic which gets people rapidly through an appropriate process if they present with jaundice. So just turning then to the patient experience, very briefly, our study for survival, which we launched in 2012, highlighted some serious shortcomings in the NHS experience of pancreatic cancer patients. That included inadequate information, poor access to available treatments, inadequate pain control and diet support, poor coordination of services, particularly palliative care. And we have experience of that, sadly, on a day-to-day basis through our support line and our specialist nurses. We again propose a number of actions in our submissions, but I just wanted to draw attention to one that's already been identified through this inquiry, and that is access to the clinical nurse specialist. We have evidence that's a real issue, and we also have evidence of how important that is in terms of the quality of patient experience. So we feel the role of the CNS must be protected during this time of change and austerity, and I know that's come out in the inquiry previously. So just very much in summary, obviously there's great progress being made. I think we're all really doing a great job moving this cause forward, but we are, without doubt, given the evidence, still letting patients down on all fronts for pancreatic cancer. And I firmly believe that unless the government responds to this, and to our call, our overall call, to prioritise pancreatic cancer as a cancer health issue in the cancer reform strategy, that pancreatic cancer will become, if not the biggest, certainly one of the biggest cancer problems in the next 10 years, and it already is a big problem. So thank you for allowing me a few minutes.
Let's go from now, Whitney. You can go on to Ali.
Should we take them
All right, yeah. Ali, do you want to follow on?
Yeah. With Pancreatic Cancer Action, our key focus is on early diagnosis of pancreatic cancer, and we are involved in raising awareness of the signs and symptoms of the disease, and also an educational element to GPs and other clinicians. And we've written an e-learning module for GPs alongside the RCGP, and we're currently writing one with the BMJ for hospital doctors and lots of other ways. Also trying to raise public awareness of the signs and symptoms, because we know from our research that not many people know about pancreatic cancer. So from our point of view, early diagnosis is absolutely key, because at the moment there is such a lack of investment funding, as Maggie will probably go on to explain, that even if something was found in a lab today that might improve treatment for pancreatic cancer patients, it could take at least 10 to 15 years to reach the clinical environment, and even longer to benefit patients. So in the interim, we need to focus on early diagnosis as a priority. And the reason why we do, it's not, I celebrated last week 6 years of survival after diagnosis for pancreatic cancer. So those of us who are diagnosed in time for surgery, which is what we want to achieve, people have a tenfold increase in their chance of surviving 5 years. So we've got to get those patients to surgical resection. We would like to see better access for GPs to diagnostic tests. I think there was some evidence in one of the sessions earlier that GPs themselves would also like to have that access available to them. And I think the previous barriers in terms of cost are no longer applicable now, as CTs are everywhere. And this will have an impact in terms of speeding up the diagnostic process. And obviously Alex has already alluded to some of the delays in diagnosis. And it's not just people not going to their GPs or GPs missing symptoms. It's sometimes actually getting people into tests in the first place. So that will speed things up. And as we know with pancreatic cancer, time is of the essence for symptomatic patients. And this is also something that can be done now within the structure of the NHS. And I think also on a wider issue, we need to have a look at the reform of the GP system as it stands currently. They are acting as gatekeepers, and we have problems with patients not being able to access GPs out of hours. My own practice used to run a Saturday morning surgery. It no longer does so. So for minor issues, you dial 111, and I had to take my son to A&E on a Saturday morning with something that a GP could easily have treated. So it's not just the problem with misdiagnosis, it's actually access to GPs, especially out of hours. And I think there should be a much wider awareness campaign of the signs and symptoms of pancreatic cancer. And I would like to see the Department of Health helping us in the charitable sector to actually push that out alongside some of the very excellent campaigns that have gone forward for colorectal cancer and lung cancer previously. And I think in terms of early diagnosis, I think the holy grail is finding a diagnostic biomarker, an easy serum blood test, urine test, saliva test, whatever test, whether we're looking at microRNAs or proteins or whatever, but that needs to be pushed forward in terms of research. Now we come down to the funding issue again, and again I'm repeating again and again the fact that pancreatic cancer received last year 4.6 million, down nearly 13% on 2011 from the NCRI partners. This can't continue, and then it's left to us in the charitable sector for personal public donations to fund other forms of research. So, and I think also the research community needs to step up and talk to one another internationally on a more collaborative level to try and find this, because this isn't exclusive to the UK. This is a global problem of diagnosis. And we also, I mean, we focus on early diagnosis, but we do talk to patients an awful lot and their families, and we are seeing that patients are still having issues with access to proper treatments in the UK. And there's no sort of universal approach. There are some patients who are not being seen by a specialist. I've had a patient 80 years of age who is actually being seen by a geriatric consultant, not a pancreatic cancer specialist. You know, the improving outcomes guidance in 2001 was supposed to sort this out. It's not happening. So that guidance either needs updating or somebody needs to take another look at it and implement what's written there or rewrite it so it's a bit more effective. The other thing is that we also need to make sure that cross-border access to care is much clearer in the cancer world. We've got a case study going on at the moment with a patient, and we can submit details of that if you wish, whereby we've got a patient who was seen on a second opinion in England who was given an option of combination chemotherapy in England, but the consultant in Wales has refused to fund it. So this patient has been denied the latest treatment because she lives in Wales. And the option is maybe they're looking at renting a place in England temporarily so that they can get that treatment. That's just not acceptable. The other thing is, you know, we know the poor rates of survival. The knows about this disease hasn't improved in 40 years. We lag behind the rest of the world in 5 years survival. We lag behind Europe in 1 year survival, particularly the French. I need to mention the French because that's important. But so what are they doing differently? We need to know what are they doing differently to us. Now, at the moment, there's the HCP Euro Index, which is a benchmarking scheme. I'm involved in that, and we're providing evidence from the UK. Getting that evidence to this body is quite difficult, because what we don't have in England is a picture of the landscape of what is happening with patient services for pancreatic cancer. Yes, we can pull out discrete bits of information in terms of surgical rates here, mortality rates, or we can see how many people might have a CT scan. You know, all this kind of stuff from different places. We need some kind of logic, some kind of cohesion to bring it all together. And I think what we need is a pancreatic cancer audit in England. There currently is precedent for that. They're doing great stuff in Scotland. I've got a copy of it here, which I will let you have today. And from that, we will not only know where there is best practice in pancreatic cancer patient services, but we will also be able to develop a set of QPIs, quality performance indicators, so where you know, clinicians can be properly assessed and benchmarked against each other, with the hope that this will bring up you know, the level of patient care in all parts, not just in some of these very, very good specialist centres across the UK. You know, and you know, currently we're sort of trying to navigate without a compass, and we really need some clarity and some direction. And I think that's something that absolutely the Department of Health could help develop is an audit, a national audit for pancreatic cancer. And again, research investment. I'm banging on and banging on and banging on. 4.6 million a year is pitiful. And we can see that there is a direct correlation between investment in research and improvement in survival rates. You know, 5 year survival rates for breast cancer in the 1970s were 56%. it's now 87%. And you can see there is a graph, and you can see correlation, increase in funding, increase in survival. Pancreatic cancer is at the bottom of the graph because there's been no increase in funding and no increase in survival. That's what I want to say today. Thank you for listening.
Right. Well, shall we go on to funding then, Maggie?
You can put the boat
Let you in beautifully, I think.
Yes, I'm Maggie Blanks, the founder of a charity called Pancreatic Cancer Research Fund, which I hope tells you what we do. We focus exclusively on funding research into defeating pancreatic cancer. I set up the charity 9 years ago after my husband's death from pancreatic cancer. And when I looked into things after his death, it rapidly became very apparent that, as you've heard many times before, that the 5-year survival rate then was 3%, as it had been for decades, that the amount of research funding going into pancreatic cancer specifically from the major funding bodies was tiny. It was less than £1 million in that particular year, and that's the total spend on pancreatic cancer research by the major funding organisations in the UK. And also at that time there wasn't very much charitable representation for pancreatic cancer. And with those three things, I felt, well, we really could go on for some more decades with not much happening. And I was so outraged, I suppose, by this state of affairs that although I hadn't set out to start a charity, because heaven knows we're 160,000 odd, we've got plenty already, but if there wasn't anyone fighting the corner for pancreatic cancer, I wasn't prepared to let that go on, and for Alan, my husband's death, and all the other pancreatic cancer patients' deaths to change nothing. So PCRF was set up with just the focus on funding more research. To date, we are funding, or have funded, £4 million worth with 27 projects around the UK. And the range of projects is trying to address the range of challenges that pancreatic cancer presents, from an early diagnostic test, which Ali's alluded to looking for more effective treatments and ways to monitor the effectiveness of treatments. So we're really trying to hit as many of the obstacles and challenges as possible. Yes, I echo Ali's disappointment that the national spend, as reflected by the NCRI partners, last year was lower than the year before, at 4-point-something million. And because our last spend on for our 2012 award round, where we accepted 6 projects for funding, that was for a total of £1 million. So we, PCRF, as a two-man charity, is funding 20% of the nation's pancreatic cancer research. And I would like
there was a woman involved.
Sorry?
I thought there was a woman involved.
Two-person charity. Research, as we've heard, is key to helping improve survival rates. And it may well be, as I've read in some of the earlier communications about the APPG and its interests, that it may be that research specifically is another separate area of investigation. Yeah. But I would just add that it does have something to say, obviously, about certainly 2 of the 3 challenges that are reflected in the paperwork to do with today: early diagnosis and bringing UK current survival rates up to par with the rest of the world, and certainly Europe. with early diagnosis, there are lots of pieces to that particular puzzle, the puzzle and challenge of early diagnosis. You've heard lots already about the need for GP education and awareness, and the need to sort of speed up the movement of patients through the process once symptoms have been diagnosed. But as we know, pancreatic cancer poses many challenges, and one of them is that in the early stages of the disease, very often there are no symptoms. And we know of patients where they felt perfectly well until a point in time where they know they don't feel right, and they're dead 4 weeks later. And so symptom awareness, and GP awareness and training, yes, is a vital piece of the puzzle, but I would say another piece that has to be looked at very seriously is the research that's going to provide an early diagnostic test, as Ali mentioned, finding something that will be the definitive test for pancreatic cancer, not tests that exist at the moment that say, well, the liver function doesn't look right, we ought to investigate further, or the CA19-9 levels are a bit suspicious. That in itself isn't the definitive diagnosis for pancreatic cancer. There is research going on into defining the biomarker, or probably panel biomarkers, that can be developed into a diagnostic test. One of the projects we're funding is looking at that, but there's research around the UK and the rest of the world into this area. But it needs more funding, it needs more effort, it needs more help. And just as a passing comment, the research project we're funding is looking for biomarkers in urine, and that could then become a very cheap, quick, efficient, simple test that maybe could become part of a future screening process. I mean, that's very long-term thinking. But if we're dealing with a disease where symptoms may not turn up until it's pretty advanced, then screening, moving the potential for diagnosis sooner into the development, earlier into the development of disease is important. And so having some simple, cheap test that maybe could be considered for a screening application would be a real help. And my by the way was to say that the BARTS project is researching into biomarkers in urine. Many of our supporters who can get access to central London have joined our campaign to P for PCRF. Fantastic. Because the researcher in question needs urine and ideally blood samples from healthy people as the comparison with the pancreatic cancer patient population. So I throw open the invitation to, well, sample pot. Yes, I say to
there'll be a large bucket,
Eric, and as many of your fellow MPs as possible. We can send a research officer. He can camp in the Houses of Parliament somewhere and invite as many of you as possible to P for PCRF. So thank you for that. So the early diagnosis, I think the research has something to... It's another piece of the puzzle. Yeah. And they're all important, and the effort for that is also important. And also, on this early diagnosis challenge, because we're dealing with something that when symptoms are appearing to be identified, it can be already too late. There's another area of thinking which is being developed now about, well, okay, we can't at the minute, we don't have the mechanisms to do mass screening. We haven't got the test for it anyway, but if we're talking about screening like there is for, say, breast cancer, well, breast cancer is half the population because it's only females, and there's a certain age group at which it starts. With pancreatic cancer, it's men and women, and what age group do you start at? So another route to think about in order to begin to tackle some of the early diagnosis challenges is to say, well, what about the high-risk groups? Chronic pancreatitis patients, hereditary pancreatitis patients, and interestingly, and it still needs to be researched more, early onset diabetes seem to be, certainly the early onset diabetes is a factor, potentially, that goes on to become pancreatic cancer. And early onset diabetes has a subtype, type 3, which seems to be particularly implicated in what become pancreatic cancer patients. And so I think this is an area, given the numbers of diabetics in the UK, I think this is an area of research that's just beginning, but there's not much happening here. There's more effort going on in the US to start to say, maybe this is an area of exploration we need to get behind. I would say if you're wanting to address the early diagnosis challenge and surveying and monitoring high-risk potential pancreatic cancer patients is an important element of making a dent in that early diagnosis challenge. But it needs research, and the research needs funding. And I haven't got any more hours in the day to kind of raise any more money, so so can the DOH and the NIHR please do something to help that? And then finally, the third challenge that's mentioned in this paperwork about bringing the UK up to par with the rest of Europe. I disagree. I think we shouldn't be saying, OK, we want to be at 6%. We should be saying, we're more ambitious than that. We want survival rates, ideally to be 100% by next month. But, of course, that's not going to happen. But I think, yes, the practices, where are the best practices? What are they? Have we got them here? Is a vital area to look at and explore. But don't let's just hook our ship to, the UK, USA, Canada seems to have 5% or 6% 5-year survival rate. That's still pitiful. We can do better than that. Let's be ambitious and say, no, we don't just want to be on a par with the rest of Europe or the rest of the world, or the best in the world. We want to exceed it. And that's, again, through a whole host of different pieces of the puzzle, both symptom awareness, more research, orchestration, best practice, and so on. But let's do a kind of John Kennedy. In 10 years, we can get a man on the moon, he said. And the nation pledged money and effort to make it happen. Well, can we do something like that for pancreatic cancer? Okay.
Really good, Mike. Thanks. Nick?
It's hard to follow that, in as far as, your testimony is very thorough, and you're people who have been living and breathing this area of disease for a long time, so you know a lot about it and shares. If we just focus a bit more on research for a minute, there's been references to sort of where the global pattern is in research. Is there anywhere that you're aware of where the global research effort is being brought together, or there's some, not just Maggie but Ali and Alex? Is that happening anywhere, and if it's happening, where is it happening?
There are conferences which are international, which bring together researchers, and there's a European network that brings together researchers
across
Europe.
What network, sorry?
It's a network that essentially is focusing on particular trials, I believe. The John Near-Thomas's work that he's doing with...
There's a lady there trying to come in. Go on.
In fact, that's to do with hereditary pancreatic cancer, so that's collaborative.
It's a very specific project, but...
I think
on this point? Yeah, go on.
On this point specifically, I can help out.
Thank you.
Large European Union-funded consortia, both funding research and funding networks networks. So, for example, researchers at Liverpool are involved in 2 European Union consortia with at least 6 or 7 member states and 20 different partners, and then a large networking consortium with currently 24 European countries involved, trying to establish networks of people involved in pancreatic cancer research in order to work together and make more progress together.
I don't think there's an obvious shining example anywhere that
I don't know of anything
that
else.
operates in that way. It is beginning to develop, aside from those particular networks. The conferences, there are certainly more. There have been a real kind of clutch of conferences in the last couple of years, really large, high-pad conferences that are focusing on, say, pancreatic cancer or pancreatic disease, and that in itself is encouraging. And some of our funded researchers have been to those conferences in the last couple of years presenting their work. And what they're saying is that those provide opportunities to really discuss and share ideas and build on other people's thinking and so on. But it's probably organic rather than sort of structured in any way.
I think that's true, and it's, I think sometimes you do get within the research community, which I was involved with before I did this. People are protective in the research community of their research, certainly before publication, and it's trying to break down some of those barriers and actually getting people collaborating around the globe on a similar piece of research, sort of the UK taking this part and the US taking that part. This may well be happening, but it's I don't think there is any formal structure, and it's trying to get the scientific community to be less protective over the research, but that's really difficult.
Actually, there is the International Cancer Genome Consortium, which is focusing on the sort of building on the developments in understanding the human genome and its implications for different cancers. So that has been a very kind of world-based collaborative effort, not just for pancreatic cancer, though, a range of cancers, but certainly pancreatic cancer was one of the areas that was funded for investigation of trying to get a better understanding of what are the genes that go wrong that then lead to pancreatic cancer. So, but that's just kind of one small area of the whole potential area for research.
And are our European partners in places like America, are they spending more money than we are on this? Or is there essentially a similar low priority for pancreatic cancer research across the globe?
I think the messages from all the different countries, whether you group Europe or just look at the USA or Australia or whatever it is, that the messaging is the same as ours. Yeah. That whatever the spend is, and whether it's a total of governmental and charitable, or whether in some of the countries it's just governmental, the spend is a tiny proportion of the spend on cancers in total.
Yeah, so if the spend is low, it's even more important, well, as well as arguing for increasing the spend, it's even more important that pressures are put in the system to maximise the global benefit of that spend, isn't it, in the way in which you've described, particularly as spelt out in terms of challenging the cultures that currently are around the scientific community.
And absolutely, and also to avoid duplication, because the resources are so small that if you've got a group of scientists working on something in the UK that's identical or very similar to those in the US, perhaps maybe it's better for collaboration on that piece of research than the doubling up of spend on one area. So it could be that's important.
And is this an issue that's been we're raising it here through our all-party parliamentary group here at Westminster, but is it an issue that's been raised at European Parliament level and the European Union? Because it does, there is an association there which maybe is worth pushing on if that's a way of maximising.
I'm not entirely sure about European, but certainly in the US. And there was a motion passed in Congress, and I can't remember the name of it, but it was to do with the funding...
Recalcitrant Cancer Act.
Yeah.
So it was to do with the funding of rarer and less common cancers, and that was done by the Pancreatic Cancer Action Network in the USA. They were really pushing for that, along with other organisations as well, and that got passed through.
That had a research focus,
yes.
didn't it? Research funding focus.
It only took them, what, 15 years to get it passed?
You mentioned this fall in funding. Was there a reason, or was it just part of the general government?
Well, I'm hoping that if there are reps from the DOH here, that's something they could answer.
Right.
What
you haven't seen any explanation.
I've tried to get to that sort of understanding, because the NCRI, as you're probably aware, National Cancer Research, is a kind of an umbrella organisation of charitable, governmental, pharmaceutical sectors. And they produced, amongst other things, this data set of what's the total spend on site-specific cancers. And yes, the 2012 figure showed, I think it was sort of 4.8 million for pancreatic cancer, whereas the year before, in 2011, it was 5.4 million. And so I thought, that's interesting. I wonder what's behind that. But I've not had any luck in persuading NCRI because they have to ask their members if they can release the figures. I haven't yet been able to get any kind of insight into, okay, who are the contributors to that new 4.8 million?
Right.
And so I can go and talk to them and say, what's happening here? Why is it less? And DOH and NIHR would be part of the funding that makes up that total figure.
Well, we could follow that up. We could ask.
Yeah.
Thank you.
I think Cancer Research UK are making a commitment to increase quite substantially their pancreatic cancer research fund.
Yeah.
Whether that will happen or not, I don't know.
All
but
right.
that's what we have. That's
Ali,
what we understand.
Ali, you raised, sorry, I'm watching time as well, so don't worry. You mentioned about this improving outcomes 2001. Was that across cancers, or what was it?
It was improving outcomes guidance for
Just for pancreatic cancer?
I think it was for upper GI. Yeah, so it was. And yes, I mean that was 2001. I don't think there's been an update since.
And your point was that this was good advice, but it doesn't seem to be having any impact.
Well, I think it has had some impact in some areas, but it's
inconsistent impact.
Yeah,
absolutely.
Right. That's interesting. The other thing I thought, which I want someone to note down across this, is that obviously one of the purposes when we get some recommendations from the detailed stuff you're putting in, and that new evidence is really interesting, Alex, in terms of that, is a thought for when we produce what we produce. It'd be nice to have a kind of almost a tick sheet for fellow MPs to ask their health and wellbeing boards, which are now constructed, which is supposed to be scrutinising what is going on in the health service, but an easy tick sheet for them to ask, is this being looked at in terms of, might be an easy, it just occurred to me then, and I don't want to, not that I forget things, of course, but it might just happen. Look, I'm really grateful. I want to move on to the others. And as you know, I mean, well, you three know better than whatever. And I'm really grateful for that. Some really good stuff there.
Thank you.
Thank you very much.